Hi everybody. So this is the part 2 of chapter 6 in myopia control progression control classes. Now this brings us to the most in thing right now, the most discussed thing right now about red light therapy and the low level red light therapy, the RLRL therapy, which has in recent past, I would say in a couple of years, it has gained significant attention as a very different approach for managing myopia. Now, it has now been believed that it inhibits myopia progression by reducing the axial elongation and progression of SER, that is spherical equivalent refraction. Now, how do you do it? The way is very simple. One of the devices I have shown in this particular slide, which is from iRising, no financial interest, but this is one of the devices, and I will be showing or talking about multiple devices which are now available, which are there for giving a low level, low intensity red light, typically around a wavelength of 630 to 650 nanometers for short durations of 15 minutes, twice a day, once a day. Uh, Now, this particular therapy is done daily for a period, and then they have shown that it inhibits myopia progression. In fact, in some of the recent literature, I was reading an article in AJO 2025, and I would be talking about it in this talk also, that it actually decreases myopia. So it is actually reducing the size of the globe. So that is what is the current thought process from some of the articles which are now published in peer-reviewed literature. So red light therapy, there have been, if you see, there will be multiple articles which are coming on repeated low level red light therapy, whether it is the game changer, whether it is the next wave, whether this would be the actual thing which can not only slow down the myopia progression, but may reverse in some of the cases in early myopes. It may delay the onset of myopia in pre-myopic patients. They have talked about the longitudinal changes and predictive value of choroidal thickness. So they are talking about oxidative stress being reduced and talking about macular choroidal thickness in myopia children. And then there are multiple articles on what exactly the red light does and how it is being used. You can see some of the articles published in 2023, and there are follow-up articles for low-level red light therapy. Now, before we talk about the results of what has been done, or what is now being published, or what are the machines available, we should be knowing a little bit about how exactly it is working. Now, there have been multiple articles on different wavelengths having different effect on the eye power, axial elongation, axial length changes. Some work has been done from LVPI group by Pawan Varkicharla and his associates, where they have tried to show that actually it is the blue light which is more, more protective compared to the red light. And then there are multiple articles on red light actually helping out in biomodulation and gradually trying to reduce the progression of myopia. Whereas the work from Pawan Varkicharla is mainly in adults and for a very short duration. The red light has been evaluated in animals. Even the blue light has been evaluated in chickens and rats, and they have suggested that blue light actually induces myopia progression, and the red light is monochromatic, and so it does help in molecular biomodulation. Not only for eyes, the red light therapy has been proposed for multiple other therapies also. So here the proposed mechanism involves not only photobiomodulation but also dopamine enhanced nitric oxide release, which may contribute to myopia control. Basically, what it is doing is that it is being regulated, the photomodulation, biomodulation is being regulated by cytochrome C oxidase, and that mainly works at it is the main photoreceptors at the level of red and infrared spectrum. So what it is doing is it is sending back ROS signaling, and it is sending back gene expressions which is modulating the scleral remodeling, the choroidal thickening, and thereby reducing the axial elongation, or in some cases, not only inhibiting myopia progression but reversing it also. Also, there are some theories that it actually causes dopamine enhanced NO release, nitric oxide release, and also the fact that it improves choroidal blood perfusion and thereby increasing choroidal thickening. So multiple at multiple levels, red light is working, or we have no idea where it is working. So these are the two ends of the thought process, because once you have multiple theories for something, either you have no idea which particular theory it is working, that is fine. So that is what is very similar to what had happened in low concentration atropine also. The fact that we knew that it is working, but the theories are still amiss about atropine and how it is affecting the myopia control. Similarly, even in the red light therapy, we really don't know at what level it is working and what is being done by red light in this particular case in reducing the axial elongation. So these are the list of all the mechanisms from the meta-analysis or from whatever has been published. Choroidal thickening, the target tissue is choroid. The effect is mechanical resistance to elongation, causing choroidal thickening by improving the blood flow. It induces mitochondrial activation at the level of retina and sclera, and this affects the cellular health, reduces anti-inflammation, it induces dopamine release, very similar to what atropine does. It resets emmetropization and thereby prevents overall growth, that has also been talked about. It basically the circadian regulation, it maintains or restores the biological rhythm, and thereby the target tissue is retina, and that there are some theories that if you are waking up at night or your circadian regulation or rhythm is broken, that can also cause myopia progression. And this red light sort of resets the circadian regulation and thereby prevents further axial elongation. The theory is that it also works at the level of scleral biomechanics. It changes and modifies it and increases the stiffness, and thereby the sclera resists expansion. Now, the basic premise, which I understand, the common sense says that if you have multimodal mechanism of action, we truly don't know at what level it is working and what is the exact mechanism of action. So there will be multiple things. Whatever the author or the person who is doing the study, whatever machine he is using, like see everything, like choroidal thickening would also reduce myopia progression, similar to scleral biomechanics and similar to dopamine increase. So whether it is one thing leading to rest of the things, and only because we have measured choroidal thickening pre and post study, we may say that it is actually the choroidal thickening which is occurring, and it may be possible that something else is occurring and that is leading to choroidal thickening. So we will not take it at this point of time. We will not go into the actual mechanism, what exactly it is. These are proposed mechanisms, and as we all are students of science, we do have multiple mechanism of actions in mind, but we have to keep on looking for more evidence, because everything that is new, everything that comes very rapidly, we may jump on the wagon to think that this is the final answer, and in the hindsight we become wiser. We understand that something was being done by this and something else was also being done. So at this point of time, we would just take home the message that there is red light therapy, it works. These could be the mechanism of actions, and then keep looking further as to what really could be the mechanism of action. Now, can red light slow down myopia? This was a question which was asked when the machines were introduced. Again, one of the machines very similar to the eye rising machine. This is also a similar machine which has a charging port. The child has to sit for 15 minutes, uh, uh, and there are multiple therapies. You have to take down this. This is low level intensity red light therapy. Another machine by Equinox, which also has a similar red light therapy. And so what exactly is the efficacy? This is really a new modality of treatment, has come up only in the last 4 5 years. So there is a lot of literature, but very little literature actually is there, which is really good, which can be understood. So this is a good article. This is actually a review article where they have tried to evaluate around 14 15 studies. They have tried to see the RCTs. They have tried to use methodology to understand uh, what are the changes, what is the really the weighted mean difference, which means that whether it is really a biased one study or not. So in their conclusion, they do believe that it is definitely effective in delaying the progression of myopia. uh, the evidence is low certainty, and larger and better RCTs would be needed. That is what they concluded in 2021. So this was one of the meta-analysis from 13 studies, which was involving around 1857 children. Three were non-randomized control trials, so mainly of no use. They were mainly observational studies. And this is a very recent article, just published a couple of months back. Uh, Axial shortening effect of repeated low-level red light therapy. Very tall claim. Axial shortening effect means that you're actually you can reverse, you can reverse the growth of eyeball which has already taken place. If you see, it is an RCT done over 1 year, 3 minutes per session, not really 15 minutes, just 3 minutes. And I have sat on the machine. You cannot tolerate it for 15 minutes. It is indeed 3 minutes per session, and very small sessions. But even though they talk about low level red light, it is not really low level. I myself could feel lot of after images. I sat there only, I think, for a minute, and I could have lot of after images. But definitely, if it is safe, and if the children can tolerate it at this point of time, they do have evidence that it is working much better, much tighter control compared to single vision spectacles. And the next class would be on combination therapies, which does have combination of ortho K with low level red light intensity therapy sessions also. Now, how does it work? I think what works there is that the kids, they give the machine, and 3 minutes per session, twice daily, 4 hours apart, 7 days a week, over 12 months. So pretty heavy dose every day, 2 times a day. You have to remember that 7 days a week. Uh, uh, the way I see it working in India is that as myopia control practitioners, we will have to buy the machine, and patient will have to come to us, because the machine, at least the eye rising machine, they were quoting a price of approximately 1.5 to 2.5 lakhs. This was last year. uh, so if it is that expensive a machine, it is less likely that patient will buy it. We may have to rent it out for a year or 2 years maybe, because the myopia may progress over a period of 2 to 3 years. And 3 minutes per session, twice daily, 7 days. I think what we have to do is we have to looking at how it is, how a model is going to work in India, is that we will have to take a machine, give it to a person, just like a Potter or a Rapido person, or a Zomato person, and he will have to roam around with the machine, because it is very difficult for patients to travel twice a day to your clinic for 3 minute session, which is very small session, 7 days a week over a period of 2 years. So this is going to be very different kind of intervention. But let us first talk about the article in picture. So mechanism, we discussed how it is working. Limitations of this study was that it was just a 1 year this thing. It was just a 1 year study. As you can see, axial length change at the end of 1 year, they found that in the group of repeated low level intensity red light therapy, it was 0.06, that was in minus. So the axial length actually did not increase, rather it decreased from their perspective. And in the control group, it did increase by 0.34 millimeters, and the spherical equivalent change was plus 0.11 and minus 0.75 in the control group, which were on single vision spectacles. So they did suggest that substantial axial shortening occurred in almost 53% of the eyes, and by substantial they meant 5 microns, which is 0.05 millimeters. Now, before I move further, I would take a small 20 seconds to talk about the fact that this particular 0.05 millimeter is too low from any perspective, because there have been talks about this at multiple forums, and I have heard some of the meetings where the researchers have said that the machine's intratest variability is 0.01 millimeter. Maybe in adults, maybe at the same time, if you take it twice in a span of 15 minutes, it may be 0.01. But when you have a different operator, when you really have a different time, and when you have kids in picture, I won't go with 0.05 as a very reliable index, because regardless of how good or how extremely good the machine is, when we are talking about kids who are between 6 to 12 years of age, it is really a very small change which has been considered. Now, yes, promising results are definitely there, and so they have said that it is one of the most potent non-pharmacological interventions for pediatric myopia. They have said that it's a class 1 laser device, and it has got very few side effects, and they say that it is quite safe. Yes, we need a consensus. So that itself, when we talk and say that there is a need for consensus on wavelength, power, dosage, and treatment duration, what it means is that whatever is safe at this point of time may not be safe or standardized after a year, once we have done enough number of trials to prove that that particular wavelength was too powerful, or the power at which we were delivering was too powerful, and the dosage was more than what was needed, and even lower dosage are equally efficacious. So at this point of time, yes, it does work, but a lot of work needs to be done. Comparative RCTs, I would say that comparative RCTs are important, but more important is standardization of wavelength, power, dosage, and treatment duration, because there is, as at this point of time, there are a couple of machines in the market, no real consensus as to what has to be done with regards to the standardization of wavelength, power, and dosage. If we see multiple articles which have been published, there are few articles where they have tried to see the efficacy. 3 minute duration, twice a day. So that is quite standard. Key outcomes, they said there was a 65% axial shortening, reversal of axial elongation, improved choroidal thickness, no significant side effects, parental compliance, and strong predictor of success. And this current study did say that axial shortening has been reported. You can see that axial change versus treated versus control, and the spherical equivalent refraction change between treated and control. So yes, in multiple studies, bulk of them are from China. This is a multicentric study, but 12 months, 6 months, not a very long-term study. But yes, it does say that there is some evidence that low level red light therapy is going to stay, but it needs a lot of more work, especially I would say not really on frequency and dose, but because there are multiple studies already done, especially on the power and the wavelength. So that needs to be evaluated, and long-term side effects, because safety is really a concern when it comes to a device which is relatively new. We really don't know what is going on, and there have been reports. One of the reports does suggest that it worsened heredamacular degeneration in one of the patients, and also there were multiple reports at least which did suggest that kids had migraine, lot of after images. So after images are quite common, at least from my personal experience. I can say that after images are quite common when you give this to the patient. If we go through this article, it does say that red light instruments for myopia at this point of time does exceed safety limits, and they have talked about how it is giving a point source of 654 nanometer with zero point 0.2 milliwatts of power. They do suggest that this is definitely more than what, or rather it can be reduced further. So yes, wavelength and power which is being delivered, uh, they can be tightened further. I don't know, because we, honestly speaking, we have no experience at all of this particular device. We have never worked on this particular device to say for sure with experience that it is safe or not. That is to be seen by the safety device, by the safety committee device, who would give approval. But yes, this article is definitely striking, where it does talk about how these red light instruments for myopia exceed the safety limits. And this is one of the interesting articles. It's an old article, not really on myopia, but tinted lenses and related therapies for learning disabilities. But can we, so this leads us to a small possibility that can we use a red tinted glass during outdoor activity? So can we use it for 10 to 15 minutes, in at least in pre-myopes, or in very low myopes? We can ask the patient, we can put that red tint in the glass and tell them to sit outdoors, because definitely the power of that particular, the amount of luminance that will be there outdoor will far outweigh the amount of luminance that we are giving through these particular devices. And then we don't have to look directly at the sun, but just sitting outdoors with red tinted glass. So that's a possibility. At this, we are doing some work on that. We are trying to at least tell pre-myopes to sit outside with red tinted glass, and that we feel that that may tell us whether they are progressing further or not. So that was regarding red light therapy. At this point of time, not really controversial, not very early days, but still quite early days to really comment upon the wavelength and dosage. Right now the device is not available in the country. I think some of the people are working on creating indigenous devices. I think there are some clinical trials which are going on with the devices, especially with the iRising company. They are doing some trials in down south. Maybe this may be a very good non-pharmacological tool in future. The problem, at least from Indian scenario, would be cost, and more importantly the delivery system, because in India the device has to be available 24/7, not 24/7 but 7 days a week, twice a day, for 3-minute therapy. Patient has to come to the clinic, or device has to go to the patient's house. So I think it would be little bit of a challenge to really deliver the device to the patient. Another bit of challenge would be to know the feedback from the kid, whether it is creating any migraine or after images, and whether this can be given before going to the school, because it may affect, it may have after images, and those things, at least in the kids. So that particular part has to be taken care of before it becomes a common therapy in India, cost and delivery system. So that was regarding the red light, low level red light therapy. And thank you so much again. We will discuss about multiple articles and the theory and practice of ortho K and red light therapy. Thank you so much, and have a great day ahead.